This film is in two parts. The first part is an overview of newborn blood spot screening, covering how and why the tests are done and how newborn screening fits into the broader context of public health care. It also provides an explanation of the disorders that are tested for by newborn screening. The second part of the film is designed as an instructional guide for health practitioners who are involved in the collection of blood spot samples for newborn screening. Alex is just minutes old. As is the case with every new baby, his future is hard to predict. He may one day have children of his own and live to be over 100 years old. Medical science is increasingly enabling us to predict if he is likely to grow and develop normally. Like every newborn baby in Australia, in 2 days' time a small sample of his blood will be collected for screening tests for a number of congenital conditions. This film explains how and why these tests are done.
The neonatal screening test is the most important test every child will have. What we aim to do with the test is to pick up children who are completely well and stop them getting sick. So the screening test tests well children who have no sign that they might have a problem, picks up problems which they are born with, so we can then go on and treat them.
Yeah, everything was fine, and then I came home early, so they came to my mum's house and did the Guthrie test, and we didn't hear anything back and we thought everything was fine, and then we got a phone call from one of the doctors at the Women's and Children's, and he tried to explain to me over the phone, but I was sort of listening, but as soon as they sort of said, Jackson's got this wrong with him, I thought, instantly a really bad thing, I thought, but then once everything was explained, it's really not that bad.
We diagnose the babies at a time when they're well. We can start appropriate treatment, which in the case of Jackson is very simple in that we avoid fasting for long periods of time, which means he eats frequent meals. If he were to be seriously ill with vomiting or diarrhoea, we'd have him come to the hospital where we could give him the necessary treatment here. So early diagnosis, early treatment means that we can prevent any nasty things happening to him.
We thought we were very lucky to find out before anything bad had happened. That way, nothing will happen because we'll make sure of it. We'll do everything right so that nothing goes wrong.
Newborn screening is recognised internationally as an essential preventable public health program. In Australia, over 250,000 infants are tested every year. As is the case with Jackson and thousands of babies like him, these screening tests can detect serious health problems in the newborn before any harm is done, and usually before there is any sign a problem exists. The screening test was pioneered in the early 1960s by an American doctor, Robert Guthrie. He developed a technique for testing blood phenylketonuria, a disorder more commonly known as PKU. PKU is an easily treatable condition when detected within the first few days of life. Since Dr. Guthrie pioneered newborn screening, technology has greatly advanced so that today blood spots can be tested for over 30 different disorders. Immunoassays and tandem mass spectrometry represent major technological advances, allowing newborn infants to be tested for a group of inherited disorders known as inborn errors of metabolism. 3mm discs are punched from the blood spot on the collection cards in the laboratory and prepared for testing. From a single 3mm blood spot, the tandem mass spectrometer can test for over 30 inborn errors of metabolism. Conditions that can be tested for by screening include congenital hypothyroidism, cystic fibrosis, galactosemia, amino acid breakdown disorders, for example phenylketonuria, or more commonly known as PKU, and fatty acid oxidation defects, for example MCAD deficiency. More than 1 in 1,000 babies will have one of the disorders we screen for. The thyroid gland is located in the neck, and its function is to produce the hormone thyroxine. Thyroxine is an extremely important hormone for normal growth and development. Congenital hypothyroidism arises when the thyroid gland fails to develop normally and the baby is not able to produce enough of the hormone thyroxine. Early detection of this disorder helps to prevent serious health problems such as growth retardation and delays in mental development.
The importance of early diagnosis in these disorders means that we can pick up babies when they're well so that they never get sick. For congenital hypothyroidism, the treatment is replacing the body's missing hormone, thyroxine. It's very cheap, readily available, easily treatable. With early diagnosis and good and regular treatment, these babies are completely normal children and young adults.
Cystic fibrosis is an inherited disorder which affects the mucus-producing glands and sweat glands of the body. The mucus that is made is very thick and sticky because it contains the wrong amounts of salt and water. Babies born with this disorder have problems with the normal function of the lungs and gut. The thick mucus blocks the small air passages in the lungs, encouraging repeated lung infections and lung damage. Problems with enzyme secretion from the pancreas also impede the ability of the gut to digest and absorb food. Cystic fibrosis is a disorder that does not affect the brain.
For cystic fibrosis, it's really important to pick up the children while they're still well. We can pay good attention to nutrition and stop them getting infections by regular treatment with antibiotics.
Several inherited disorders affect the breakdown of amino acids, which are the building blocks for protein. PKU is the most common disorder in this group. Babies born with PKU cannot break down the amino acid phenylalanine. If untreated, high levels of phenylalanine are toxic and will cause damage to the brain. Treatment for these children involves changing the diet to avoid foods that contain high levels of protein. This child was diagnosed with PKU shortly after birth. He has a special diet with a protein-based supplement which has been given to him since birth. By continuing this diet and learning which foods are appropriate to eat, he will continue to live his life without being affected by this disorder.
For example, PKU, undiagnosed, untreated, means irreversible mental retardation, seizures, and the inability to function independently in almost all cases. With early detection and early treatment, these children are normal young people and adults.
Lactose is a sugar present in human and animal milks. Lactose is usually broken down by the body into galactose and glucose. Babies born with galactosemia cannot break down galactose. The treatment for this is to exclude foods that are the major source of galactose, for example milk and some dairy products, and other foods where lactose is added during manufacture, such as some breads, cakes and margarine. Children with galactosemia need to maintain this diet for life. Left untreated, galactose builds up in the body, causing a number of different harmful effects, such as cataracts, brain and liver damage, and can be fatal in infancy. As a baby, Jackson was detected with a disorder known as MCAD deficiency. MCAD deficiency is an example of a group of disorders known as fatty acid oxidation defects. Babies born with a fatty acid oxidation defect cannot use their stored fat to produce energy in times of stress or sickness. This results in the body using up all its sugar in the blood for energy. Low blood sugar can be fatal if left untreated. MCAD deficiency is just one example of a fatty acid oxidation defect. There are a number of disorders in this group which vary in severity and treatment depending on the specific fat involved.
The fatty acid oxidation defects are really interesting. They're only a recently recognised group of disorders that were started to be picked in the mid-80s. Children are perfectly well unless their body is stressed by something like an extra long time between meals or being sick with a virus. But when these children get sick, they can become very, very ill with low blood sugar, coma, and even death. If we know your child has one of these problems, we can institute proper treatment so that there is no long period of fast, so the body doesn't break down fats, and so that the child then can lead an essentially normal life within the limits of their dietary restrictions. For the long-chain fatty acid oxidation problems, the treatment is a lot more complex and the disease is a lot more serious. We have to actually exclude fat from the diet in addition to treating with missing things like carnitine. Occasionally parents feel that it's not worth having their child tested because these disorders are so rare. And what I'd like to say to you is that although each of the disorders is individually rare, if we put them all together, 1 in 800 children will have a problem that we can pick up on newborn screening. We know it's a very anxious time when we call families and say that the child that they thought was completely normal might have a problem. Skilled counselling and experience in the management really dramatically reduces the anxiety felt by families under these circumstances, and I can't remember a family who've not been grateful to know that their child had a problem and that we could do something about it.
The reliability of the screening test is dependent on two main things: the correct timing of the blood collection and the quality of the specimen contained. The timing of the sample collection is critical. Collect the specimen from infants when they are 48 to 72 hours of age. This allows for early metabolic changes and for the commencement of milk feeds to take effect. Samples collected too early may give false negative results. Samples collected too late may place children with health problems at risk of irreversible damage. Premature and sick infants are a challenge for any newborn screening program. Many hospitals collect several specimens over the period of hospitalization. As a minimum, a specimen should be collected 48 hours after birth and again at 1 month of age for those with a birth weight less than 1.5 kilograms. It is important to check your institution's protocol before taking the sample. With many women going home 24 to 48 hours after the birth, practitioners must be vigilant in their care to ensure that all babies are screened at the appropriate time. Remember that it is the sole responsibility of the hospital of birth or independent midwife to ensure that the blood sample is collected, promptly sent to the laboratory, and the collection recorded in the infant's medical records. Of equal importance to timing is the quality of each specimen received by the screening laboratory. Test results will only be reliable if a quality specimen is obtained. A quality specimen will have all requested information completed for accurate identification, all circles saturated and covered with a uniform cover of blood so that they look identical on the front and the back. The card should be air-dried for 4 hours and dispatched to the screening laboratory on the day of collection. All positive results will be notified to the doctor, whose name appears on the newborn screening card for follow-up and diagnostic testing. Any borderline results, requiring collection of a repeat newborn screening sample, will usually be notified to the nominated liaison staff member of the hospital of birth. A confirmation report is mailed fortnightly to the birthing hospitals or independent midwife. The hospital or independent midwife has the responsibility to ensure that the tests for each baby are received and checked against the birth records. Repeat samples required for babies whose original sample was unsuitable for accurate testing will be indicated on the confirmation report, as well as a letter mailed to the hospital. It is essential to cross-check that all babies have been screened and accounted for. In the event of a baby not appearing on the confirmation report, the newborn screening liaison person must notify the newborn screening laboratory. The following procedure for a heel prick and capillary blood collection has been designed to assist the inexperienced operator. The actual collection technique is an acquired skill and takes time to master. Identify that the timing is correct and the baby is due for the screening test. It is important to obtain the parent's consent prior to the sample being taken. Explain the procedure and make sure that the parents understand the reasons for the test. The newborn screening information pamphlet should be provided to the parents at the time the baby is having its collection to ensure they are fully informed about the tests and their outcomes. Opportunities should be made for the parents to view the education film. Discuss this information with the parents and ensure that you answer any questions that they might have. Explain to the parents that they will only be informed about the results if the test is positive or borderline. Parents may refuse to have their baby screened. In this case, the paediatrician must discuss this further with the parents. If they still refuse, this must be documented in the baby's medical records. It is also advisable that the parents sign the appropriate documentation indicating their refusal and are asked to complete the newborn screening refusal questionnaire. Before you take the blood sample, it is important to know if you have the correct baby. Check the identification band against the medical records. After identification, make sure you wrap the baby warmly while you prepare to do the procedure. Ask the mother or father, "Is this your baby?"
Melanie, is this your baby?
For a home visit, you will need to check your referral form and other documentation with the parent, as the baby will not have an identification band. Before starting the procedure, complete all the details on the newborn screening test collection card using a ballpoint pen. It is important, in order to process the sample accurately, to record the date and time of birth, date and time of collection, details of feed type, any relevant clinical details, and surnames of both mother and baby. When handling the card, be careful not to touch the circle area on the filter paper. The next step is to wash your hands. You will need the following equipment: a retractable lancet, an alcohol swab, 3 cotton balls, disposable gloves, the screening card, the baby's medical records and personal health record book. The choice of the skin puncturing device is important. Use only a recommended semi-automatic or retractable lancet with a maximum blade depth of 2 millimeters. Position the baby so that the heel is the lowest part of the body. The test should, if possible, be done when breastfeeding, or you can position the baby by tilting the cot or having the mother hold the baby to her shoulder. You are now ready to select the site for the puncture. It is critical to avoid the calcaneus or heel bone and the nerves and arteries in this area. Heel punctures in the newborn should be performed on the plantar surface of the heel. Imagine a line drawn from the middle of the great toe to the heel, and another from between toes 4 and 5 to the heel. The puncture is made on the most medial or lateral aspect of the heel, as seen in the shaded areas. Do not puncture on the posterior curvature of the heel, as this is where the calcaneus bone is the closest to the skin surface, or through previous puncture sites. Assess the colour and temperature of the baby's foot. Is it pink and warm? If it is pink and warm, no further warming is necessary. If the baby's foot is cold, put on booties and wrap in a warm blanket for a while before attempting the procedure. Alternatively, take the sample immediately after a warm bath or ask his mother to warm the foot in her hand. The next stage is to put on gloves. Wipe the area to be punctured with the alcohol swab and then wipe it dry with the first cotton ball. Do not use petroleum jelly or any other material on the heel prior to collection, as this may contaminate the sample. Hold the heel firmly to expose the medial or lateral site to be punctured. Note the placement of the midwife's hand. The index and middle finger hold the baby's leg, whilst the thumb wraps around the base of the baby's foot. This is the same grip from the other side. She is taking care not to apply digital pressure to the lower limb or foot. This can cause bruising. She is also taking care to keep the foot in its natural position. Excessive dorsiflexion is painful. Here is an alternative grip. The index and middle fingers are placed around opposite sides of the baby's lower leg. The baby's foot fits snugly into the gap between the thumb and forefinger. The thumb is used to hold the bottom of the baby's foot steady. This grip is often used on smaller birth weight babies. Hold the semi-automatic lancet between the thumb and forefinger with the tip placed against the puncture site and maintain steady pressure. Depress the plunger, pause for a split second, then release. After puncturing, wait. Count to 5 before attempting to collect any blood, as vasoconstriction will occur immediately following puncture. Wipe away the first drop of blood, which contains tissue fluids, with the second cotton ball. Wait for a second large drop of blood to form and then lightly touch it to the center of the first circle. Apply gentle intermittent pressure with the thumb to the area surrounding the puncture site. Don't rush the procedure. Allow time for capillaries to refill after the collection of each drop. Then move on to the other circles, filling them in the same manner. Use the third cotton ball to place over the puncture site until bleeding stops. Spot adhesives are not recommended because of baby's sensitive skin. Once collection is complete, the card should be kept horizontally to allow even spread of blood and placed immediately into an appropriate drying rack, or if this is not available, over the edge of a bench or table. This prevents contamination. Comfort and settle the baby. If you are experiencing difficulties in collection, perform a second puncture. You will require new equipment for this, and you will need to apply blood to a new circle on the card. It is important that you don't puncture through the previous puncture site. Select another site and start the procedure from the beginning. If you still experience difficulties, stop. Seek help from a senior or more experienced collector. Once collection is completed, further documentation is required. Record that you have collected the newborn screening sample in the baby's hospital records and in the personal medical record folder nicknamed the Blue Book. All other details as required by your institution must be recorded. The screening collection card should be placed horizontally in a drying rack and air-dried for a minimum of 4 hours at room temperature. If you are an independent or domiciliary midwife, a small insulating container is useful to protect the cards. Holes must be punched in the lid to allow air circulation around the cards and a drying rack cut to fit. Remember, keep the cards separate. Avoid excess heat, cold and direct sunlight. The collection cards must be completely dry before being placed in an envelope for mailing. Cards should be packed alternating the spots in this manner to prevent contamination between samples. Wrap the cards carefully in plain paper and then place into a pre-addressed envelope and seal it. This double wrapping is required by the Postal Service. The envelope should be addressed to the laboratory and sent on the day of collection. Do not place cards into a plastic bag, as this may result in bacterial growth and an unsuitable sample. If samples are deemed unsatisfactory for analysis by the screening laboratory, the baby will need to be recalled for a second collection. Common problems include insufficient volume of blood collected. In this example, only one circle has been filled. There is no opportunity for further testing to either confirm or exclude a positive or borderline result. In the second example, the circles are filled with many small spots of blood. This is a very common problem, and it could occur if the collector is inexperienced and afraid of pricking the baby too hard. If the lancet is not used effectively, there will not be enough blood flow to fill the card. This problem may also occur if the collector attempts to perform the procedure too quickly, not allowing enough time for large blood drops to form. Blood saturation is also important. Note in this example one side appears acceptable, but when the card is turned over, the blood has not soaked through. Lack of uniformity of blood saturation is also a common problem. Note in this example there are darkened areas within the circles. This usually indicates that the operator has performed a double collection, placing fresh blood on top of already partially dry blood. This causes a range of problems with the analysis of the sample and will result in requiring collection of a repeat specimen from the baby. Contamination can occur during collection, storage or mailing. Exposure of the specimen to potentially interfering agents such as water, soaps, feces, alcohol, iodine antiseptics, dirt, talc or lipstick will render the test unreliable. Drying the cards inappropriately is also a problem. Placing a sample which is not completely dry into an envelope may allow bacterial growth. Excessive cold separates the blood cells and serum, while excessive heat and exposure to direct sunlight has the effect of baking the sample. In this example, note the periphery of the circles illustrating separation of the red blood cells and serum. Specimens showing the slightest signs of separation must be recollected. Newborn screening is important, and you have a vital role to play. Early diagnosis of children with problems that can be picked up with newborn screening allows for earlier treatment and the avoidance of potential life-threatening problems in the future. Following the simple steps shown in this program will ensure you have fulfilled your responsibilities and know you are contributing to helping children live happy and productive lives.